This is a hospital, and in it lies a sickly 10-year-old child. He's not doing really well at the moment. He presented a few days earlier with fever and cough. Seems innocent at first, but then he became progressively tachypneic, restless and in distress. It seems like there is a problem with the lungs. Let us have a look. The lungs are having a very hard time to expand. In other words, its compliance is significantly compromised due to the pathology affecting the lungs. He is then intubated for worsening respiratory distress. However, when the patient is connected to the ventilator, a few alarms went off. The pressure is too high, the tidal volume is too low, and you're having a difficulty ventilating the patient. This can all be explained by learning about lung compliance. This is Mastering Anesthesia, so stay tuned and let's go.
So let's talk about lung compliance. It is defined as a change in lung volume produced by a unit change in transpulmonary pressure. In other words, it's how much your lungs expand after a given pressure. So when we say a lung has high compliance, it means that when a small pressure is applied, big change in volume is observed. Contrasting that with a lung with low compliance, it means that high pressure will only cause a small change in volume, and a bigger pressure is needed to achieve the same volume as the lungs with high compliance. Let's have a look at some examples, shall we? Here we're going to see the difference between a high compliance balloon versus a low compliance balloon. We have with us a thin balloon and a thick balloon. Let's say we give them each 2 units of pressure. The thin balloon will expand to almost twice its size, whereas the thick balloon barely changes at all. Therefore, you need greater pressure to achieve a greater volume. In mathematical terms, compliance is equal to change in volume per unit change in transpulmonary pressure. A subtle yet important detail to be pointed out here is that it is transpulmonary pressure instead of just pulmonary pressure. Transpulmonary pressure is the difference between alveolar pressure and interpleural pressure. Alveolar pressure is the pressure inside the lungs. Meanwhile, intrapleural pressure is the pressure inside the pleural cavity, assisting or resisting the expansion of the lungs. Therefore, the use of transpulmonary pressure reflects the true distending pressure. Now let's see what happens during a normal tidal breathing. Normal tidal breathing starts when the lung is at FRC, or functional residual capacity. At this point, the lung is at rest, where the inward elastic recoil of the lung, depicted here, is equal and opposite to the force that tends to spring the thoracic cage outwards. These balance of forces occur at FRC, and you've probably known that lungs are most compliant at FRC. This means that work of breathing at rest is very minimal. A normal lung compliance is about 200 mL per centimeter of water. This translates to a tidal volume of 500 mL, only requires a transpulmonary pressure of only 2.5 centimeters water. This is equivalent to 200 times 2.5. So we've talked about lung compliance, but what about respiratory compliance? Are they the same? No, they are not the same. Respiratory compliance refers to the compliance of the whole lung-chest unit. They consist of 2 components, the lung compliance as well as the thoracic cage compliance. So how are they mathematically related? Or how do they sum up? Owing to their arrangement like so, imagine they are arranged as an electric circuit. They are arranged in a series, not a parallel circuit. Therefore, when you want to add up, they add up in inverses. Therefore, 1 over respiratory compliance is equal to 1 over lung compliance plus 1 over thoracic cage compliance. Both of the individual lung compliance and thoracic compliance has a compliance of 200 mL per centimeter of water. Adding them up, we will have a respiratory compliance is equal to 100 mL per centimeter of water. Remember that since they add up in inverses, the overall compliance of the chest wall unit is always less than the sum of its parts. Moving on to factors affecting lung compliance and thoracic cage compliance. The thoracic cage compliance is affected mostly by the shape of the chest wall, including the spine and the rib cage, as well as muscle tone. Meanwhile, lung compliance is affected by elastic recoil of the lung connective tissue, as well as surface tension by the air fluid interface in the alveoli. Now let's see how respiratory compliance is affected by different clinical situations. Let's see some causes which increases the lung compliance and those that reduces lung compliance. In emphysema, the lung will have increased compliance due to the destruction of lung elastic tissue. Advancing age will also have increased compliance due to the degeneration of elastic tissue. And neuromuscular disorders, the lung compliance will increase because of the reduction in muscle tone. Therefore, the lungs and the chest wall can easily expand. Next, some factors that reduces lung compliance. Number one is posture. Basically and generally, the lung will be less compliant in supine position. Number two, pregnancy. Obviously, the gravid uterus will reduce the thoracic cage compliance. Number three, fluids. Whether they are in the alveoli or interstitium, this will increase the surface tension inside the lungs and greater pressure will be required to expand the lungs. Number four, atelectasis. When the lung units collapse, the radius reduces. Owing to Laplace's law, which will be explained later, there will be increased transmural pressure required to expand back the lung. 5. Pulmonary hypertension. In this case, the capillaries will be engorged with blood. Therefore, the lungs will have a greater resistance to expand, reducing its compliance. 6. Pulmonary fibrosis. Number 7. Extremes of lung volumes. When the lung is at very high capacity in inspiration, the elastic tissues are fully stretched. Therefore, the capacity to increase in volume further is further reduced because the elastic tissue are at its max. Meanwhile, at low lung volumes, probably there will be atelectasis at the basis, so greater volume is needed to expand back the atelectatic lung units. And lastly, you have obesity and chest wall deformity. Now let's talk about surface tension and role of surfactant. Surface tension is caused by forces of attraction between water molecules. They do this to minimize air-fluid interface. How do they achieve this? They join together to form a spherical droplet. At this point, the air-fluid interface is minimum. So depicting this in an alveoli, you have water molecules in the alveolus. The forces of attraction between water molecule will force the alveoli to collapse inwards. Like so. Opposing this force to expand the alveolus is the alveolar transpulmonary pressure. The alveolus obeys the Laplace's law, where pressure, surface tension, and radius are related. P is equal to 2T over R. P is transpulmonary pressure, T is surface tension, and R is the radius of the alveolus. Now let's see how surface tension causes a lot of problems in the lungs. In expiration, the alveolus will become smaller, and when it becomes smaller, the radius will become less. Obeying this Laplace's law, when radius is reduced, a greater transpulmonary pressure is needed to reinflate the lungs, provided the surface tension remains the same. Number 2, there will be collapse of some smaller alveoli into the bigger alveoli. Some alveolar sacs are inherently connected to each other, therefore the smaller alveoli in the lungs will always collapse into the bigger alveoli owing to the surface tension, because the small alveoli have less radius, therefore the pressure is high. So it collapses into the bigger alveoli, which has less pressure. The third problem will be transudation of interstitial fluid into the alveolus. So as you can see, the surface tension exerted by the water molecules will draw in fluid from the interstitium into the alveolus. All of these troubling problems can be easily solved with pulmonary surfactant. They are produced by type 2 pneumocyte. They comprise a mixture of phospholipids, prominently DPPC, dipalmitoyl, phosphatidylcholine. Quite a mouthful. Now let's see how it helps in reducing surface tension. You have these water molecules exerting surface tension into the alveoli, and this surfactant is interspersed between these water molecules. They repulse each other. So on expiration, when the radius of the alveoli becomes less, the surfactant comes closer together and exert negative repulsive forces between each other, forcing the alveolus to remain open, resisting surface tension that draws the alveolus into collapse. The surfactant align themselves along the alveoli because they have the hydrophobic site and the hydrophilic site. You can see they repulse each other, preventing alveoli from collapse even at low lung volumes. Thank you so much for watching this video. You've reached the end of the first part of lung compliance. Next, we're going to talk about static and dynamic compliance, hysteresis, and many more. If you enjoyed this video, please click the like button, and if not already subscribed, please do so. Thank you so much. See you in my next video.